All right, this is chapter 10. It's going to be patient assessment. Pretty important chapter as far as your care and at the advanced AEMT level, due to the level of ALS care you may be given at time. So this part of your standard of care applies clean information and patient assessment findings as far as things size up, primary and secondary assessment, patient history and reassessment to guide emergency management. So we're going to be looking at scene safety as far as your size up, making sure that scene is safe, scene management, impact of the environment on patient care, addressing some hazards if there is any, violence, of course. We're not trained to or equipped to handle a lot of violence, need for additional or specialized resources. Standard precaution and multiple patient situations. Also, in your primary assessment, for all patient situations, you're going to want to look at LOC, your ABCs, identify your life threats, assessment of vital functions, and initial general impression. Begin interventions needed to preserve life and integration of treatment procedures needed to preserve life also. History taking is very important. So you want to determine that chief complaint. Notice I said that chief complaint. Mechanism of injury, nature of illness, associated with signs and symptoms, investigation of the chief complaint, past medical history, and pertinent negative. In your secondary assessment, you're going to want to do performing a rapid full body scan, focus assessment of your pain, and assessment of your vital signs continuum. Technique of physical examination as far as respiratory systems, presence of breath sounds, cardiovascular system, neurologic system, musculoskeletal system, and all anatomic regions. Assessment of lung, using some new and more in-depth monitoring devices, obtaining and using information from patient monitoring devices, including pulse ox, non-invasive blood pressure, and monitoring your glucose. Then in your reassessment, you want to know how and when to reassess patients, how and when to perform a reassessment for all patient situations. All right. So, in order to begin your patient care, you must be comfortable and also master the patient assessment process. It is used in every patient encounter. One thing I will say is, your patient assessment needs to be in a order that you're comfortable with. If you treat all patient assessments, close and to the same, a lot of times you won't miss anything, and it's something that you can get in the routine of doing for every patient. So that process consists of scene size up, primary assessment, history taking, secondary assessment, and then getting into your reassessment. So it is going to depend on the order that you do this. Is going to depend on the patient's condition. So you may need to do your primary assessment first before getting really in depth with that scene size up and history taking. You may have some life threats that need to be corrected really quick, and then you can take a more in-depth look into that same size up. Some critical thinking skills. You need to be able to gather information, evaluate, and synthesize patient information. Um, you need to develop an idea of what the patient's problem and formulate a field impression. So, um, as far as gathering information, observe the scene and question the patient and bystanders. Um, get all the information you can from people that are there. Um, people that are maybe friends or bystanders may have seen what happened. Sometimes you need to get on the phone and talk to family members that may have heard something different from the patient, and even when talking to them on the phone or whatever. So don't forget about that technological piece also. Evaluating information, you need to consider the meaning of gathered information, prioritize them accordingly. So people a lot of times will give you a bunch of information at one time. Especially if you get into a trauma situation and you have multiple people around you that see different parts of what happened, trying to gather all that information together and make sense out of it, and make it into a sequential event. Integrate the information you obtain regarding the current incident with similar situations and experiences, and articulate assessment-based decisions and construct arguments. So, that field impression is going to be something that you get all the information from, and you kind of gather an idea of what's going on with that patient. It's sort of like a doctor's diagnosis, but we really can't diagnose what is going on with this patient. We can take the signs and symptoms and everything going on and say, hey, you possibly having a CHF event. You are having a STEMI event. Here's your 12 lead. That's a field impression. That doctor's going to make the final diagnosis. That doctor's, going to say, hey, yes, you're having a heart attack. And they're going to evaluate this information. So, we gather the information up, we take the signs and symptoms, and we put it together to make a field impression of what's going on. All right, so size up. You start this as soon as you start rolling it on the thing. You scan the window survey. Is what I heard one time when doing a part-time evaluation. You're looking through the windows of the ambulance, and you're trying to assess what's going on. Whether it be a multi-vehicle wreck or a single vehicle wreck, a house fire, a burn patient, due to possible explosion, or maybe it be a medical call that you're rolling up to a house on. Hey, this patient's got a ramp, so there must be some kind of chronic conditions probably going on with this patient, or how are we going to approach this thing? Maybe it's too wet in the backyard next to the ramp, and you need to park the ambulance somewhere else. And how are we going to get all of our equipment up to that home? Is it well-maintained home from the outside looking in? So, continuous situational awareness is necessary throughout the call. Pay attention to the conditions and people around you at all times, and consider environmental conditions. I look at conditions all the time, even when I'm off duty. I'm always looking to see, what people are doing. I'm a people watcher. If I could get paid to watch people all the time, that would be great. But I'm looking at their manners, looking at the patient's manners. Is this situation getting better or worse? Are they getting ill-tempered? Are they getting more laid back? They're finally glad that help is here, and they're thankful that help is here. And how can we, continue to promote that situation? Or is the patient getting upset more because we're getting asked more questions? And how can we, degrade this situation and make it better for the patient? Prepare for a specific situation based on initial dispatch information. Consider a variety of factors that will impact how you operate on the scene and provide patient care. Do you have road and traffic hazards? Do you need to be putting on vest and wear your PPE and maybe possibly a helmet, OSHA approved helmet? Incident hazards while you're on scene. Is there a puddle of oil, blood already on the scene? And how do we get around it? Um, even on a medical call, are those steps or is that ramp strong enough to hold everything? That patient on that stretcher with you walking down that ramp. That could be a hazard itself too. It's the floor inside of our home. Is it a hazard to you? Is there holes in it? Could you fall through a hole? I've been in plenty of situations where I've told my partners not to lay down any of our equipment due to hazards of even a medical call, a stump toe call. Silent correction, things of violence. We try to. I always try to keep our people out of a violent thing that could become worse quick. Also, try to limit a crime scene down to one person, because you got to understand that a criminal investigation could take, as far as taking your boots um, off your person to rule out that boot print in a investigative manner, or limit the number of personnel that go into a scene, or limit the amount of time we spent on a scene, doing assessments and doing treatment. So it's always something to think about. So things times up must be combined with an understanding of the situation based on information the dispatcher provides with your observation of the scene itself. And right now, our dispatchers are only giving stuff as the caller is giving it. Is that looking at changing in the near future? It is, with FaceTime and different things like that, and Skype, and how phones can bring up videos really quickly. People are going to be able to text the scene to 911, so they can give you more accurate scene information. So, but always remember the caller is the one providing the information. The dispatcher can only do and say what that caller is giving them. So a lot of times it's wrong, but that's not the dispatcher's fault. But as you arrive on scene, you need to do your own assessment of that thing, size up. Ensure scene safety, consider traffic safety, look for hazards, take your patient and bystanders. So every pre-hospital scene has potential for injury. It doesn't matter, stump toe, to the high mechanism trauma call. All these things have potential for injury. Always ensure safety for yourself and your partner first. Always remember that. Always ensure safety for yourself and your partner, then your partner first. Then the other responders may be there with you, and bystanders are second, and your patient is last. Okay. Look for possible dangers as you approach the scene, and before you step out of the vehicle, look for hazards found at the scene. Traffic. We always stress traffic. We look at the TIMS model as far as trying to control traffic. Does it always get implemented? No. That's why I always try to work with local fire department. A lot of times these guys have it set up, and most of them have a place for the ambulance to park. Just work with them. That may be the safest place. So, but if you deem that it's not safe for yourself, you can talk to them, professionally, and see if you can get something worked out so that everybody's on the same page. Chemical and biological agents at a hazardous thing or a terrorist thing, down power lines or lighting, secondary collapse, that structural collapses, fire and explosions, carbon monoxide, unstable surface. We talked about that, even floors inside our home. So when gaining access to a patient, remember that you will typically leave via the same route you enter. moving a heavy stretcher in a patient. Work in unfavorable conditions and on unstable surfaces is a large part of pre-hospital care. So, we'll fill in these stretchers that are, big frames, and seems like they're getting heavier at times, and then seems like the stability is a little bit more better over rough maneuverability of floors and outside areas and different things like that. So, you have to combine all that together. So any actions you may take to protect yourself should also be considered for the patient. Take time and stay focused on what you're doing. Try to protect bystanders from becoming patients. A lot of times we have trouble with that with bystanders, and we try to get law enforcement involved, but they're not always going to be there, or they may be busy. They're outstretched on their resources. So, I always try to help them out a little bit, or we may have to say something to those bystanders ourselves. So make them understand that sometimes they're adhering our process on what we're trying to do, and we're trying to get this patient out here as quick as possible. So be aware of things that have potential for violence and request assistance from law enforcement personnel if required. Once again, if you have a patient that's become violent towards you and it's putting yourself and your partner in harm's way, you have the right to leave that scene. Just, go down the road just far enough so that you can tell if that patient wants to leave, or if that patient does, do something, perform some act that makes their condition worse. At least you can get back to them quickly, so that you can provide that care to them. All right, try to determine the mechanism of injury. Mechanism of injury is how the patient became injured themselves. Do not immediately characterize your patient as either a trauma or a medical patient. Some patients do fall into both categories. That fall patient that just kind of tripped, or that initial shortness of breath patient that had a syncope episode and then fell, and now you have a syncope episode problem with a fall problem, and the pelvic region may be sustained an injury then. So now you have a medical / a trauma patient. So considering the mechanism of injury or nature of illness early, it will help you prepare for the rest of your assessment. You need to be able to identify all the aspects of the emergency to which you will call to respond to. So you've got to take everything into consideration, all aspects of the scene itself, so that you can put together this picture. Because you got to remember, you're bringing that picture of what you've seen to the emergency room, because those doctors and those nurses are not always out there in the field. Luckily we do have a smartphone capability nowadays, and sometimes we take pictures. Please be careful with those pictures if you're taking with a personal phone. That could end up in a legal dispute. You never know. So, the mechanism of injury is traumatic injuries are the result of physical forces applied to the outside of the body. Classified according to the type or amount of force applied, the length of time the force was applied, and where it was applied on the body. So, you got to look at, what kind of force was applied. Was it a blunt force object versus a penetrating object? The length of time it was there, was it a hot cooling object, or did it go in and make a cavitation throughout, and which part of the body it went to? Next, mechanism of injury describes how the patient became injured. Determining mechanism of injury will provide many clues to help you focus on your assessment. It will give you many clues as to the process of the injury and what could be potentially the injury. That we see here, we have a front end collision with a full-size truck. So we're looking at up and over maybe the steering wheel, or possibly down and under the steering wheel. So we're looking at a lot of trauma along the long axis of the body, and possible chest trauma too. So blunt trauma occurs over a broad area. Skin is not broken. Penetrating trauma occurs at a specific point of contact between skin, and the object. So in a penetrating trauma, you always got to think about infection also. That's why paramedics have those options too, with the ANSTF being introduced here recently. So, and we always want to keep this penetrating trauma area sterile as possible with our care, as far as applying gauze and different things like that. So, same size of nature of the illness: seizure, heart attack, diabetic condition, poisoning. Um, this is an effort to determine the general type of illness and nature of the illness. It's best described by the patient's chief complaint and medical history. So, talk with the patient, family, and the bystanders about the emergency and why they called the ambulance today. They're going to give you the best clues as to what happened today. He was talking fine, and all of a sudden started slurring speech, and then it went back. He was talking fine again. She has occasionally been having shortness of breath for a couple of days now, but the day is, worsening the past 30 minutes to the point that, they can't make them complaints in it, or, they're slurring their speech again, or they're altered, and we don't know exactly what's going on. So, determine the number of patients put in the actual mass casualty plan. I always remember that mass casualty is a trivial event that poses more patients than your system can actually handle at one time. So you need to know how many, keep in mind on a daily basis how many ambulances you have on duty and what you can handle. So most MCIs will implement the ICS system as far as calling for additional resources and begin your triage. So you're going to take incident command, start doing logistical factors as far as knowing what types of resources you may need. More ALS backup, more fire departments that may do more than fire suppression. They may provide you with EMS care at different levels, and law enforcement personnel that can handle, maybe traffic hazards, or some law enforcement personnel also medically trained up to a certain level. That's where you need to know your particular system that you are functioning within. So then you start triaging. Triaging is a process of sorting patients based on their severity of conditions. So it helps allocate personnel, equipment, and resources to provide the most effective care for everyone. Most triage systems use the green, yellow, red, and black color coding, and we'll go over that probably more in later chapters. So, think about your medical too, and then, as you start triaging, you got to possibly start doing into that operational PPT as far as where you need your particular units at and what units you need where, as far as sorting them out and getting those to the getting proper units to the proper patient. So, some specialized equipment and gear that may be needed, maybe from your fire department or rescue personnel also. You may have fire suppression, technical rescue, vehicle electrification that needs to be done, high angle rope rescue, hazardous materials, and swiftwater rescue. So search teams can help find patients, package and transport patients over long distances and across uneven terrain. Law enforcement personnel may be needed to control traffic and intervene in potential violent situations. So stage yourself and your vehicle at a safe distance until the scene has been secured. So, can that thing go south once you arrive on the scene? As far as it being secure, yes, you can. And that's where you'll have to make judgments yourself and your personal safety and your partner's safety. You may have to go back down the road somewhere until they can get that thing back secured again. So always ask yourself during that thing size up, how many patients are present, are enough resources available to respond to their conditions, and does the scene pose a threat to you, your patient, or other. It is never wrong to call for backup, even if the extra units are instructed to be, turned back and turn around and cancel. I love to allocate resources, and I try not to use a whole lot of resources on one thing unless it's absolutely mandatory. So I may send another unit behind the initial unit routine just in case they're needed. And then I can turn them around, or I can, um, defer them to another call. Always, try to ask your dispatch center, also, ask them to keep you up to date. They give you updates on the scene condition. A lot of times they can give you, possible X number of PIs, and that way you can kind of start seeing the resources up that way, due to that action also. All right, then your primary survey, your immediate goal is to identify and initiate treatment or of immediate life threats. So do your physical exam of the patient to assess the level of consciousness and airway breathing, circulation, disabilities, and exposures. You want to put that A, B, C, D, E in. We always used to say ABCs. Now we've got that disability and exposure in there also during the initial primary survey. So this is not an in-depth exam, nor assessment of vital signs. So always give priority to life threats. Have they got an airway problem? Do we need to put OPA in? Have they got a arterial bleed? Do we need to attack it with pressure first, or do we need to go straight to that tourniquet? So all those life threats, something that needs to be done quickly. Also look at that exposure. Also, are they in a potentially bad scene, and we need to do a emergent move on these patients to get them out of that potential hazardous area. So, form a general impression. Note the patient's appearance and position. Does the patient appear to have a life-threatening condition? What part of the patient was the patient injured? What was the mechanism of injury? And does the patient seem coherent and able to answer questions? So, first part of the primary survey is determine the priority of the patient's emergency medical care. Easy or red, easy or yellow. I always try to triage all of my patients. Is it a co-stroke patient? That's a red patient. We don't need to be sitting on scene with these patients. I try to keep it in that 10-minute window and get them off the scene. Or is this a stump toe patient? And hey, I can spend 20 minutes on scene with this patient and do what I got to do. So I always note things such as the person's age, sex, weight, level of stress, overall appearance, and the presence of any obvious bleeding. Overall visual assessment that helps you gather information as you approach the patient. We'll always try to teach you to approach these patients from feet up. That way, don't walk up behind the patient that's a trauma patient and say, hey, how are you doing? My name is so-and-so. Because what's the first thing that patient's going to do? They're going to try to turn their head and look at you. About the patient's position and whether the patient is moving or if the patient's still. You got a patient that's up walking around. Could they have a spinal fracture? Yes. Is it only a acute spinal fracture that causes damage later? Probably not. However, you've got that patient laying there on the ground supine that they're like, look, we can't feel nothing, and you got a big bleeder on the lower extremities, and that patient got an idea. You've got a major problem there, maybe a spinal fracture somewhere, and you've got the major bleed also. So maintain a high index of suspicion and begin your treatment looking at mechanisms of injury. Start thinking about what all could be injured and treat your patient off of that. Always be alert for signs of airway obstruction. Determine if the airway is open and adequate. Minor severe airway obstruction will result in inadequate or absent airflow into the body and out of the lungs, and inadequate perfusion to the entire body. So your body ain't your respiratory system is compromised. Then yes, you're going to potentially, you will have a exchange of nutrients and everything, and O2 reaching the rest of the body systemically. Your lungs have got to be able to exchange, the capillaries have got to be able to exchange that O2 and CO2. So if respiratory compromised, that O2, CO2 is not going to exchange, and you're systemically, insulting potentially the whole body. Determine if the airway is open, patent, and adequate. If it's open, patent, what we need to do. You need to do is like head tilt chin lift, put an OPA in on EPA. And do we need to get that nowhere breather right, quick, and apply it 15 liters, or do we need to go straight to BVM? Um, so, or do we need to go mouth to mouth, with a barrier device there? So continue to risk test the airway, and unresponsive patients should be considered to have experienced a traumatic event of some sort. So responsive patients cannot speak or cry, is less likely to have severe airway obstruction. So responsive patients who are talking and crying or moving air, a lot of parents with children always, respectively, kind of freak out sometimes. But we always try to say, that patient is crying, obviously there's air exchange there. Watching and listening to see how patients speak may provide important clues about the adequacy of their airways and status of their breathing. A responsive patient who cannot speak or cry most likely has severe airway obstruction. So stop the assessment process if an airway problem is detected and work to clear the patient's airway. So signs and symptoms of airway and breathing problems often overlap. And unresponsive patients immediately assess the patency of the airway, and they should be considered to experience a traumatic event. Unresponsive patients. So use the jaw thrust maneuver if trauma is suspected. However, that in other particular schools of thought is controversial, and identify other potential causes for obstruction. It may be just relaxation of the tongue in the back of the airway. So put that LPA down. And that OPA is also going to tell you some other stuff. If you put the OPA down, then obviously you don't have a gag reflex, and you might be able to do something about that too. So dentures, blood clots, bottomless mucus fluid, and other foreign objects may create an airway obstruction. Clear with manual techniques of suction. So signs and symptoms in unresponsive patients include obvious trauma, blood, and other obstruction, noisy breathing such as snoring, bubbling, or other abnormal breath sound. Extremely shallow, absent breathing. So your airway position depends on the age and size of your patient. Ensure adequate breathing. After you make sure the patient's airway is open, ensure breathing is adequate. A patient who is breathing without assistance is said to have spontaneous respiration, so spontaneous breathing. So ask the patient the following question, or ask the following question: does your patient appear to be choking? Is the respiratory rate too fast or too slow? Are the patient's respiration shallow or deep? Is the patient cyanotic? Do you hear abnormal breath sounds when listening to lungs? And is the patient moving air into and out of the lungs? All right, observe how much effort is required for the patient to breathe slow, shallow, or deep respirations. Labored breathing is characterized by the patient's position, concentration on breathing, and the increased effort and depth of each breath. So deep respiration can be a significant rise or fall of the chest, document when the patient's respirations are shallow in depth. Labored breathing is characterized by the patient's position, concentration of breathing, and increased effort and depth of each breath. So signs of inadequate breathing are presence of retractions, especially your pediatric population. And that's the use of abdominal muscles, and it looks like a seesaw breathing from the chest to the abdominal muscles themselves. So, patients can speak only 1 to 2 to 3 words without having to take another breath. So 2 to 3 word bits, nasal flaring, seesaw breathing, super, clavicular and intercostal retractions in the pediatric patient. So COPDs can also have that nasal flaring. I always think about that. So 2 common postures: tripod, your patient over here on the right, in that sleeping position with your patient down below. All right, next you want to do is assess your circulation, palpate the radial arterial the radial artery in responsive patients. All right, palpate the carotid artery in unresponsive patients. and then in children younger than 1, palpate the brachial pulse. So, circulation is evaluated by assessing the patient's mental status, pulse, and skin condition. So assess the pulse. Pulse is the pressure wave that occurs each time the ventricular contraction occurs. So most easily felt at the pulse point where a major artery lies on the surface. So, older than 1, palpate the radial pulse at the wrist. In unresponsive patients, go straight for that carotid to see if it, gives you a blood pressure area also. When you palpate for a pulse, do not use your thumb. Use 2 fingers and slide down to the side that you're on. If you're on that patient's left side, especially that carotid pulse, go to the left side. No pulse rate from adult, 60 to 100. All right, determine if it's present or absent, follow fast or slow, correction normal, fast or slow, weak or thread, or strong and bounding. So you need to determine the accuracy of the pulse during the secondary assessment. Here we're just trying to make sure that they have one. Can we feel it? Is it weak? What it feels like, We don't particularly want to sit there and count it. A lot of times we do count it, maybe for 15 to 10 seconds, and be able to multiply. All right, if you cannot palpate the pulse in an unresponsive patient, begin CPR. If the patient has a pulse but is not breathing, provide ventilation. So, patient has a pulse, is not breathing, provide ventilation, 10 to 12 breaths per minute for adults, and 12 to 24 for an infant or a child. So if pulse is lost, start CPR and apply AED. Never begin CPR using AED on a responsive patient. All right, assess your skin. So assessing the skin to evaluate circulation, perfusion, blood oxygen level, and body temperature. So perfusion is assessed by evaluating a patient's skin color, temperature, moisture, and capillary refill. Skin color of the skin is determined by the blood circulating through the vessels and the amount of hyperpigment present in the skin. Blood is red when adequately saturated with oxygen, and skin in lightly pigmented people is pink. In patients with deeply pigmented skin, changes in color may be apparent only in certain areas. Fingernails, beds, mucous membranes, lips, underside of arms, palms, conjunctiva of the eyes. Assess the palms of the hands and the soles of the feet in infants and children. Inadequate peripheral circulation will cause the skin to appear pale, white, ashen, or gray, possibly with a waxy, translucent appearance. Cyanosis is skin over the blood vessel appears blue and gray, and that is a sign of low oxygen in the blood. High blood pressure may cause the skin to be abnormally flush or red. Liver disease or dysfunction may cause jaundice or that yellowing of the skin. So skin temperature, normal skin is warm to the touch. Abnormal skin is hot, cold, and clammy. Significant fever, sunburn, or hypothermia will make the skin feel hot to the touch. Skin will cool when the patient is in early shock, has mild hypothermia, or has inadequate perfusion. And skin will feel cold when the patient is in profound shock. So, skin can tell you a lot about what's going on with a patient. Skin is a sign that you may see. Once you arrive at the patient's side, it can tell you really quickly, hey, we may have a perfusion problem here, and we need to do something about it quickly so that we can get that oxygen back into circulation. Capillary refill time provides an indication of a pediatric patient's level of perfusion. Just place your thumb on the fingernail and gently compress. Basically we're just going to suppress the end of a finger and see if it either stays red for a long time or if it goes back to a normal color. And this should happen less than 2 seconds. All right, assess the skin for external bleeding. Identify and immediately control any major external bleeding, whether it be your pressure or straight to the tourniquet, which we'll learn about later. So it should be performed before addressing airway or breathing problems, because you are losing that oxygen carrying capability if you do not go ahead and address it. So signs of blood loss include active bleeding from wounds or evidence of bleeding. So serious bleeding from a large vein may be characterized by steady blood flow. So bleeding from an artery is characterized by a spurting flow of blood. They do a sweep for blood by running your glove hand from head to toe. Pause periodically to see if your blood will blood. Direct pressure with a glove hand by a sterile bandage over the wound will control bleeding in most cases. So when direct pressure is not successful, or whenever you encounter an obvious arterial hemorrhage of an extremity, apply a tourniquet. Okay, restoring circulation. Take immediate action to restore and improve circulation. Apparent absence of palpable pulse in a responsive patient is indicative of a low cardiac output state. So if you cannot feel a pulse in an unresponsive adult, begin CPR, and if the AED or manual defibrillator is not readily available. So once it is available, assess the need for defibrillation. So any patient with a impaired circulation should receive high flow O2 via a non-rebreather, mask, or assisted ventilation. So like I said, also don't forget about your airway adjuncts, know that NPA, OPA. So assess the patient for disability, perform a brief neurological evaluation of the patient, make a certain gross LOC by determining if the patient falls into 3 categories. So responsive with an altered LOC, and then responsive with an unaltered LOC. Okay? So, are they clearly awake and alert, or they responsive, but they do seem altered, maybe they're not answering all your questions correct, so they got an altered LOC. Sustaining response indicates critical respiratory, circulatory, and central nervous system problem. They package the patient and provide rapid transport to the hospital. Further assessment will be required for any patient with an altered LOC. Altered LOC in a responsive patient may indicate that inadequate perfusion and oxygenation are adversely affecting the brain and its ability to function. So it can also be caused by many medications, drugs, alcohol poisoning, hypoglycemia, chemical imbalances, or other neurological conditions. So you may have a trauma, but the main reason for that trauma could be medical at the end of the day. So to determine if the patient's normal illness status, you may have to have bystanders help to do that. So any deviation from alert and oriented person, place, and timing an event so a patient's normal baseline is considered an altered mental status. Evaluate the patient's mental status and LOC just a few seconds by testing responsiveness, maybe the sound, touch, pain, or orientation. Ask them if they know where they're at. Do you hear this? Can you feel help? Can you feel this? And, a lot of times with spinal cord fractures, I'll take a sharp object sometimes to go down and bomb it up to it to really test for a neurological upset. All right, indicators of spinal mobilization include mechanisms that indicates potential for spinal injury. Either that may be blunt or penetrating trauma, any mechanism indicates potential spinal injury, pain or tenderness in the neck or spine. Patient reports pain in the neck or back. Paralysis or neurological complaint, priapism, blunt trauma with any of the following autonomic status, intoxication, difficulty or inability to communicate. Also remember with this, you need to find out with your local system about your spinal clearance protocols and policies So make sure you don't deviate off of those also. So the ASPE scale tests the patient's responsiveness, awakening alert, patient response to the verbal stimuli, patient response to pain, and non-responsive. So to determine whether a patient who does not respond to verbal stimuli will respond to a painful stimulus, gently but firmly pinch the patient's skin. A patient remains flaccid and does not move or make a sound is considered unresponsive. Orientation tests a patient's mental status by checking his or her memory and thinking ability. So the most common test evaluates the patient's ability to remember 4 things: person, place, time, and the event. So, ask them if they know what happened, how it happened, do they know what time it happened or how long ago it may have been. So GCS assigns a point value for eye-opening verbal response and motor response. And using that GCS scale, especially a lot of your trauma centers will ask you about that GCS scale. GCS scale, only thing I'll incorporate, the highest you can get 15 and the lowest you can get is 3. Gauging a patient's response to the painful stimuli, gently but firmly pinch the patient's earlobe, press on the bone above the eye, or gently pinch the muscles of the neck. All right, do your full body scan, visually inspect each area to ensure an accurate and thorough assessment. When you're finished, cover up the patient to respect his or her privacy and maintain body heat. Perform a rapidly full body scan to identify other injuries that must be managed and are protected before transport. And it takes about 60 to 90 seconds. This is a quick body scan. So guidelines on how to and what to assess during the rapid full body scan. Look at your patient's abnormalities, palpate them, touching or feeling the patient's abnormalities, auscultate, listening to body sounds using a stethoscope. So then you want to look into that DCAT BTLS mnemonic to help you in mind what to look for in inspecting and palpating various body regions. So, all inferior general conditions can cause sudden death: airway obstruction, respiratory arrest, respiratory failure, primary cardiac arrest, shock, and severe bleeding. So often these conditions are manageable, but you have to be able to recognize them quickly and take immediate steps to correct them. So identify and correct life-threatening issues begins with the assessment of ABCDE. When the patient is cardiac arrest, assess ABCDE simultaneously. Control life-threatening breathing takes priority over airway and breathing concerns. So, you do suspect spinal injury or high mechanism injuries to cause possible injury, consider spinal mobilization or early. The going on refers to the time from which the injury to definitive care, and this is the best time for survival. So, when that incident happened, it's not when these people call 911. So you always want to think, hey, how long did it take them, to call 911, or how long were they actually on scene, or something happened before they could call 911. That's when the golden hour starts. It's that initial time of insult. So I always think about the golden hour as you're at the time you dispatch, to the time you get on scene. You won't stop adding up those minutes. So the golden hour does refer to that time. That is the best potential for survival. So spend as little time as possible on the scene with the patients who have sustained significant severe trauma. So aim to assess, stabilize, and package and begin transport within that 10 minutes. So that's in this picture here is that platinum 10 minutes. So some patients may benefit from remaining on scene and receiving continued emergency medical care. So call for support from paramedics if the unit is not already en route to the scene. maybe you are that advanced EMT, highest level of care, and you do need that paramedic. Call for them earlier. They can be met while transporting the patient in critical condition. So they need to meet you en route somewhere. So don't ever forget about that till you can treat these patients and start getting them transported. Correct identification of higher priority patients in an essential aspect of the primary survey. Rapid transport is one of the keys to survival of any high priority transport. Initiate that transport as soon as practical and possible. And this means you've done that primary assessment, you've corrected those initial threats, you've got them loaded. You need to start transporting in. That's not putting heart monitor on and getting IVs. That's not stuff that needs to be done on the thing. So do not possibly register by apparently normal vital signs. Tell that patient, hey, this is been a pretty significant event, and we need to get you to a facility of appropriate care quickly. So looking at mechanism of injury again to ensure you're not missing any important information. You may have had that bleeder real quick, but hey, this was you may have chest trauma too that you're not seeing quick enough because either you covered up by clothing or you didn't recognize that steering wheel was bent. So you go back looking at mechanism of injury again. All right, history taking. So this is where you can get a lot of your details about the patient chief complaint and an account of the patient signs and symptoms. History taking is pretty important. You want to get as much history as possible on the scene from family, friends, and bystanders. Check for medical ID tags and paperwork. They may have them on their ankles somewhere. They may be wearing a dog tag somewhere, or it may be in their pot, in a wallet stuffed somewhere. So do not look for those, living wills, DNRs, most forms, different things like that too. So do not delay transport for patients who are in unstable condition. You may have a lot of people talking to you at one time, but that patient's really unstable. You need to get a quick storyline of the events that led up to them calling 911, and you need to get out of there. So a lot of times this stuff can be gathered, rationed out later once that patient is stabilized. Document all the information gathered, demographic information, past medical history, current health status, pertinent family history, recent travel history. So get an age, sex, and race. Pertinent past medical history. Have they been currently doing well with, even though their medical history is long, were they able to get up and ambulate independently, or were they having to have help, different things like that. Investigate the chief complaint, ask simple open-ended questions. Begin by making introductions and making the patient feel comfortable. Obtain permission to treat that patient. Can we help you out today? What can we do for you? Ask a few simple open-ended questions. As what's going on? What made you call today? Are you in pain? Can you tell me how and why? Use eye contact, body position, and language to show that you are concerned. About that patient, and continue speaking. Do not interrupt, and be empathetic of the patient's situation. It may be a chronic cholera patient that's doing it for several days, and maybe the receiving facilities just aren't hitting on something. So try to understand what they've all done, and see if you can gather something new to help out this patient. Gather information about the chief complaint from observable clues and information received from the original dispatch. So use family members, friends, bystanders, and other public safety personnel and ID tags to gain essential information also. So be aware of your surroundings. Maybe you noticed there's a bunch of 1cc syringes somewhere gathered up. Could this have been a insulin-dependent diabetic user, or maybe they're using it for some type of illicit drug use. And you never know what's going on with some people. But you try to use those clues that you're observing on your scene to figure it out. The next guy's history of present illness. Onset, usually OPQRS, mnemonic. So when the patient's problem began, what was the patient doing at the time of the incident? How long was the patient has noticed the problem? Especially with your medical patients, how long has it been going on? P's for provocation, or can be extremely helpful in determining the cause and severity of the patient's problem. Provoking factors, anything that seems to bring on the problem. Palliating factors, anything that brings relief for the problem. All right, quality is description of the pain they're having. Is it focal or diffuse? So carefully document the patient's own words. So avoid asking leading questions. So ask the patient, point to the area of pain, describe the area of pain, and describe pain anywhere else associated with the problem. So, if it's focal, pain in the right shoulder, or is it a diffuse pain, in a particular area, and it's going and radiating everywhere? Well, not so much radiating. It seems to cover a large area, or is it radiating pain, up and down the chest, and it's going into your left arm? So that may be something you need to look at. All right, radiating pain refers to an area of the body from which the origin of the pain or discomfort may travel. Referred pain is pain that exists in more than one place. Severity is how bad it is. Ask the patient's questions as far as how bad is the episode in comparison with previous ones. What happened the last time you had an episode of bad pain, and could you rate it on a scale of 1 to 10, 10 being the worst? So timing is questions related to time to provide information about when the problem began, and that helps you understand the nature of the problem. So interventions, ask about any treatment prior to EMS arrival to possibly overdosing these patients. So a lot of these patients may self-treat themselves or self-medicate themselves before calling on them. They may give themselves aspirin and nitrogen before you get there. And they may give themselves glucagon before you get there. They may give themselves opioid medications before you get there. So you don't want to get there and overdose them and then have another problem. Ask about any treatment prior to EMS arrival to avoid this. Identify any pertinent negatives, find as you would expect based on the patient's complaint that they are not present. Right. Are you having shortness of breath, that chest pain? Maybe not. All right, investigate past medical history. Use your mnemonic sample. So signs and symptoms, allergies, medications, pertinent past medical history, last orientate, and events leading up to the illness injury. So look at the past medical history, see where they got particular surgeries done or particular procedures done. What have they done for a particular disease they may be experiencing, or where are they in the process of treating this disease. Then use your sample, get your signs and symptoms, make sure they're not allergic to any medications, find out what medications they're actually actively taking. A patient can't have your whole suitcase, but you need to know what they're taking right now. Get that pertinent past medical history, last orientate, just in case they need to go to surgery, and the events leading up to the illness and injury. So alcohol and drugs, signs and symptoms while under the influence of alcohol and drugs may be confusing, hidden, or disguised. So patients may deny abuse of alcohol and drugs. Sometimes it can be hard to appropriately understand a patient's signs and symptoms because of the side effects of alcohol. So make sure with those patients or drugs, make sure with these patients that you do a full evaluation so that you don't skip anything. Try to establish a rapport with these patients, and make sure that you're impressed that all this stuff is confidential. So physical abuse and violence, report all cases of suspected physical abuse or domestic violence to the appropriate authorities. If you suspect a patient is a survivor of physical abuse or domestic violence, immediately involve law enforcement and look for all hidden clues such as a situation exists. So note whether the information provided by the patient or others present at the scene is inconsistent. So the patient may not answer questions because of fear of future violence, or the physical aggressor may be present and answering questions for you. So in these cases of domestic violence, involvement can be extremely, dangerous. So be observant and open-minded and have a high index of suspicion and non-judgmental. Accurate, thorough, and objective documentation is very important in these cases of abuse and domestic violence. So it may be something that the victim will not want to report, but they want to be evaluated, and they're putting on a show as far as something else is concerned. Maybe they're saying that they feel, but they've got old bruising from past injuries. So, and the aggressor may be there or the suspect, and they're trying to give you a different story to get out of the situation. So be suspicious of all of this. A lot of times the aggressor will not want these patients to be transported due to the fear that this may further cause more questions. All right, sexual history. Some patients find sharing information regarding their sexual history uncomfortable. Consider all female patients of childbearing age who report lower abdominal pain to be pregnant unless ruled out by other history or other information. When was your last menstrual period? Are your periods normal? Is there any vaginal bleeding discharge present that is not associated with a menstrual cycle? Do you have urinary frequency of burning? What's the severity of cramping? Any unpleasant odors present? Is it possible you may be pregnant? Are you taking birth control pills or any other types of birth control? How many sexual partners do you have? Have you had any recent sexual encounters? We'll deal with many patient inquire about, do you have any pain associated with urination? Do you have any discharge sores or increase in urination? Do you have any burning difficulty voiding? Any trauma occurred? How many sexual partners do you have? And have you had any recent sexual encounters? So ask about potential for sexually transmitted diseases, and all information obtained from the patient is confidential. Special challenges in obtaining patient silent patients. Be patient with these patients. Use close-ended questions that require simple yes or no answers that can shake their hairs. Either way, consider whether silence is a clue to the patient's chief complaint. Look for visual signs in the patient's environment that may indicate why a patient is not communicating. Look for nonverbal clues, including facial expressions that may show pain or fear. Overly talkative patients. Possible causes include excessive caffeine consumption, nervousness about the situation, or ingestion of cocaine or methamphetamine. Allow the patient a chance to express him or herself, and then try to direct the patient to stick to the facts by summarizing his or her statements frequently. Clarify statements for the purpose of making sure the information you are gathering is correct. And, a lot of these patients are scatterbrained. They're telling you multiple different things that are going on, and they may tell you stuff that is really not pertinent to the situation at hand. So you've got to get these patients focused down, talk about what has occurred for them to call 911 today. So multiple symptoms, spend extra time assessing the patient, prioritize patient's complaints as you would during triage, and keep an open mind and try not to focus on one complaint or detail. These patients may call and say, "Hey, look, I've been nausea and vomiting all day, but the more I vomit, I'm having chest pains, and then sometimes I am just feeling weak." So you've got multiple complaints here. You've got to prioritize these complaints. Is the chest pain, coming from the chest wall soreness from the vomiting, or could we actually have a cardiac event induced here also? So you've got to be able to differentiate which one needs to take priority over the other. Anxiety, expect anxious patients to exhibit signs of psychological shock. Be aware that emergency responses involving anxious and hysterical patients can turn violent. A lot of times these patients are highly in alert mode. So anything you do or say, any kind of facial expressions you may give, can turn these patients violent pretty quickly. Can also encounter during a routine EMS call with family members or patients cannot cope. So expect anxious patients to exhibit signs of psychological shock. Anxiety may indicate low blood glucose levels, shock, or hypoxia. So you may need to treat something else when these patients are anxious. So you make sure you do a thorough assessment to include glucose check and SpO2 check. So it's just patients that any nervous or anxious response is normal can be overcome. Be confident in your approach and have a positive demeanor. And these patients can turn violent pretty quickly. So do not take anger and frustration personally. Patients, friends, or bystanders may direct their anger and rage towards you because they're trying to get it off themselves. Remain calm, reassuring, and gentle, and be aware of nonverbal clues such as posture, position, and facial expressions that you are expressing, but also your patient is expressing. So if the scene is not safe or secure, then contact law enforcement to secure it. And never let a potentially violent or hostile patient leave the room alone. If that means a family member or even one of you of the same sex going with that patient, or just tell that patient, hey, we're not going to let you into another room without us having eyes on you. They could go into a room by themselves and either pick up something or commit an act that you don't want to have bearing on you later. So intoxicated patients, be aware of information may not only be difficult to get, but it could also possibly be unreliable. Even those bystanders, standing around that may be intoxicated also. Never assume the patient's condition is the result of alcohol consumption. Try not to put a patient in a position where he or she feels threatened and has no way out. So be accepting, diplomatic, objective, and non-judgmental. Crying, the patient may be sad, in pain, or emotionally overwhelmed. Remain calm, patient, and reassure and confidence, and maintain a soft voice. So be sympathetic and treat them with respect and dignity. Depression is the leading cause of disability worldwide. So some symptoms include sadness, like feeling hopelessness, restlessness, and irritability. So try not to be judgmental. I always try to be compassionate towards these patients. So often the patient needs someone to talk to and listen to listen to them and their feelings. All these patients can be difficult. Um, we're gonna look at some more that may be difficult also, but try to be sympathetic towards these patients. You need to remain calm as a provider also, and a lot of times that will help the patient remain calm too. All right, history taking, confusing behavior, and history. Be aware of medical causes that can lead a patient to report a confusing history. Could it be hypoxia? Could it be a stroke going on, diabetes, trauma, drug, and medication use? One of the most common confusing causes of confusion is hypoxia. Older patients may have dementia, delirium, or Alzheimer's disease. Verify the baseline mental status of each patient, and confused behavior is not normal response. Patients with limited cognitive abilities, keep your questions simple and limit the use of medical terms. Be alert for partial answers and keep asking questions. For patients with severely limited cognitive function, rely on family, caregivers, and friends to supply those answers. A lot of these patients, you will have to use other people to help gain answers to the question. All right, language barrier patients, consider using interpreters. Sometimes those are younger people there. Translation resources such as by phone, a mobile device app on your smart tablets, phones, whatever you may have. The use of hand gestures may be helpful, but however, be careful what gestures you use and make sure that it may not be offensive. Always, alert the hospital that you do have a non-English speaking patient coming in, so that they can start making preparations, themselves as far as getting an interpretation there. All right, hearing impairments range from slight to total deafness. Ask questions slowly and clearly because these patients a lot of times are very good mouth readers. May use a stethoscope to function like a hearing aid. Change the pitch of your voice that may help the patient hear you. Some patients have mastered the technique of reading lips. Speak slowly and face to face with the patient. Learn simple sign language or use the pen to hold a pen. Visual impairments. Identify yourself verbally when entering the home of a visually impaired patient. Put any items that have been moved back into the previous position. Explain to the patient what is happening and stay in contact with the patient by keeping a hand on the patient's arm or shoulder. Notify the patient when you're preparing to lift or move him or her. Explain that you will be checking vital signs and remember that you are a stranger to the patient and that he must be equal with a foreign environment. These patients use sight, they use whatever sight they have to navigate themselves. Also, they may use hearing to help navigate themselves also. We had a patient that had a certain sound in the kitchen, and they also had certain sounds down the hallway to help them navigate through their home itself. They also had rugs and certain furniture that was in particular positions to help them navigate. They knew how many steps they should take to get to a rug that may be tipped over or get to a chair that may be tipped over and have a certain feel to it. So when you take them out of that environment, you need to let them know what's going on, what sounds they may be hearing, and where you'll be touching them to evaluate them. Secondary assessment, obtain vital signs, perform a systemic physical exam of the patient. So if the patient is in a stable condition and has an isolated complaint, secondary assessment may occur at the scene. So if not, it is performed in the back of the ambulance en route to the hospital. At a minimum, assess and document the following: respirations, pulse, blood pressure, level of consciousness, AFP, possibly also the GCS scale, skin condition, Blood glucose is within normal range. Pulse oximetry also. So physical exam may be a head to toe, full body exam, or an exam that focuses on a certain area. So assess the vital signs. Remember, these devices are subject to limitations and mechanical failures. So you should never replace your comprehensive assessment of the patient. Pulse ox monitors the oxygen saturation of hemoglobin and capillary breath. So it is a useful assessment tool to determine the effectiveness of oxygen therapy, bronchodilator therapy, and artificial ventilation. So do not use with hyperperfusion or known anemia, carbon monoxide, and other exposures to toxic inhalants and cold extremities. So hyperperfusion or known anemia patients are not going to give you accurate reading of a pulse oximetry because the capillary beds do not have that hemoglobin traveling down through the capillary bed. Carbon monoxide is going to overtake the red blood cells carrying the oxygen. So in cold extremities have vasoconstricted at the extremities itself, so you're not going to get appropriate reading there too. I always try to do a room air pulse ox on a patient with significant signs and symptoms, especially respiratory nature. That way you kind of get in that base pulse ox, and as you do your treatments, you can tell has that pulse ox decline. You can document it that way also. Non-invasive blood pressure management is used on Blood Pressure Plus, auscultation, palpation, and electronic. So just always try to remember that electronic devices are prone to inaccurate readings in the motor vehicle, noisy environment, or if the cuff is not correctly sized and placed. I always take the first set of vital signs manually, regardless of the availability of an electronic device. This gives you an area to scale what you get electronically to see if it's in the range of being correct or not. Auscultation is taking it by stethoscope. Palpation is using arterial pulses to get that systolic blood pressure itself. Entitled to monitoring measures carbon dioxide levels. It is the partial pressure or maximum concentration of CO2 at the end of the exhale breath. It's measured by colorimetry, capnometry, and capnograph. Capnometry consists of disposable or electronic devices that provide measuring CO2 output. Capnography provides measurement of CO2 output in water form based on serial measurement. So we use a lot of capnography presently to give us that reading and a waveform so that we can assess our patient's respiratory status that way also. Full body exam goals to identify hidden injuries or unidentified causes. Any patient who has sustained a significant mechanism of injury is unresponsive or in critical condition should receive a full body exam after the life threats have been managed. So a patient with no suspected spinal injuries follow the steps and skill drill that we'll talk about later. Any patient, so we'll talk about a full body. So focused assessment generally performed on patients who have sustained non-significant mechanisms of injury and on responsive medical patients with a significant complaint. So a lot of this stuff is based off of their chief complaint. Focus attention on the immediate problem. So if they're having chest pain, you want to, focus on that chest pain, the chest area itself, by asking questions that relate to chest pain. Abdominal pain, we're going to talk about questions that are directly concerning abdominal pain. Is it radiating or radiating? Just think about that. All right, respiratory system, look for signs of airway obstruction and trauma to the neck or chest. Expose the patient's chest and inspect for overall symmetry. So we want the chest to go equal rise and fall. Listen carefully to breath sounds, don't have abnormalities. Do we hear something that's different, from the front to the back and the upper and the lower? Do we have breath sounds? So measure respiratory rate, chest rise and fall, and effort. Respiratory rate, normal respiratory rates for adults is 12 to 20. Jet respirations and responsive alert patient without making the patient aware of what you're doing. So a lot of times you just need to be talking to these patients, and you can kind of look down at your watch and do it that way. Respiratory rhythm, note whether the patient's respirations are regular or irregular. Quality of breathing, decreased absent breath sounds on one side of chest or decreased movement in rise and fall indicate inadequate breathing. So stridor is the upper airway obstruction caused by foreign body or swelling, bubbling, gurgling. Patient probably has fluid in passages or in the upper airway. So you can almost auscultate over the upper lung, one inch below the clavicle at the mid-clavicular line. That's your mid-lung fields, and the lower lungs at the mid-axillary line. All right, breath sounds, normal breath sounds, tracheal sounds. Normal breath sounds are clear and relatively quiet. Wheezing is a high-pitched whistle sound. It suggests obstruction or narrowing of lower airways. Crackles is a moist crackling, usually on inspiration and expiration. Bronchitis, continuous sounds with lower pitch and rattling quality, indicative of fluid in the larger airways in the lungs. Stridor is a brassy, crowing sound caused by a narrowing, swelling, or obstruction of the airway. Pleural friction rubs is squeaking or grating sound that occur when pleural linings rub together. So a patient who spits up thick yellow or green sputum most likely has an advanced respiratory infection. A patient with a chest injury may cough up blood or frothy white or pink sputum caused by blood or fluid mixing together with the air in the lungs. So depth of respiration is the amount of air that the patient exchanges depends on the rate and tidal volumes. Tidal volume is the amount of air in milliliters that is moved into and out or out of the lungs during one breath. Shallow respiration indicate a decreased tidal volume. Deep respiration indicate an increased tidal volume. Cardiovascular system, check for abnormalities in the thoracic region, such as pain or discomfort. Check for listen for breath sounds and look for trauma to the chest. Consider the pulse and respiratory rate at the blood pressure. Reevaluate the skin. Check for compare distal pulses. Make sure they're equal bilateral. Consider auscultating for abnormal heart tone. Pulse rate should be between 60 and 100 beats per minute for the average adult. Pulse rate greater than 100 beats per minute is tachycardia, and less than 60 is bradycardia. Make sure the pulse is normal. A normal pulse is strong. If it's stronger than strong, it could be described as bounding. Describe a pulse that is weak and difficult to feel as weak or thready. So the rhythm is determined whether the rhythm is regular or irregular, and if it is irregular, if the heart periodically has an early or late beat, if a pulse or if it's missed. So your rhythm should be pretty regular. It should be like a beat in a music song. So it should be consistent. All right, blood pressure decrease, and the blood pressure may indicate loss of volume. loss of vascular tone, or sufficient arterial constriction. So you may have a pumping problem, or you may have an overdose of beta blocker or hypertensive medication. As shot progresses, blood pressure will also fall. So you get that hypotension with the tachycardia. Any patient with markedly low blood pressure has inadequate pressure to maintain proper perfusion of all the vital organs. So that systolic pressure is increased pressure caused along the artery with each contraction of the ventricles and the pulseway that it produces. Diastolic pressure is residual pressure that remains in the arteries during the relaxing phase of the cycle of the heart. Blood pressure is measured in millimeters of mercury and is reported as a fraction in the form of the systolic pressure of a diastolic pressure. Avoid taking blood pressure on an arm if the patient has an IV site, central line catheter, port, a dialysis fistula shunt, and or has had a mastectomy, or even an injury to that arm. So most EMS agencies do carry at least 4 sizes: obese, adult, pediatric, and infant. A cuff that is too small may result in approximately high readings. A cuff that is too large may result in approximately low readings. Hypertension is blood pressure that is lower than the normal range, and hypertension is a blood pressure that is higher than the normal range. And that's going to depend a lot on your particular agency. Neurological assessment should be performed at any time you're confronted with a patient who has changed in mental status. Evaluate the LSD and orientation to determine the patient's ability to think. So use the Asprey scale to determine the patient's mental status. Consider the following questions to help assess the neurological system. What's the patient's activity level? What's the patient's mood and thought content? What do the patient's facial expressions tell you? Is the patient angry, fearful, depressed, or anxious, or restless? Does the patient appear uncomfortable? Does the patient make incomprehensible or understandable statements? And is the patient memory affected? Does the patient remember who family members are? What's the perception or view of what is happening? Make sure you inspect for head trauma, blood pressure, pulse, and skin changes may indicate hyperperfusion of the brain, and assess the mental status by considering whether the patient is alert and oriented in 4 areas, such as person, place, and time, and the event itself. So use this to determine their GCS score. Pupils are normally round or equal in size, so whenever bright lights are introduced, the pupils constrict. With less light, the pupils dilate. So bilateral dilated pupils that do not respond to light are usually due to death. Pearl is a useful guide in assessing the pupils, or the pupils equal round and reactive light. So if not, if you got a slight deviation, you may be suspected to potential injury on the opposite side. So make sure you always check for this. Head, neck, and cervical spine expect for abnormalities. Gently palpate scalp and skin and for pain, deformity, tenderness, crepiness, and bleeding. Check the face for rash and petechia. Assessment the eyes. Check for bruising and discoloration around the eyes and behind the ears. Check the ears and nose for fluids. Odor suggests that they need to check for blood glucose level. And they have a sweet smell on the breath, and that might be just a glucose disorder. Check the neck for swelling or bleeding. Palpate the signs for trauma. Chest, visualize, inspect, palpate over the chest areas for injury or signs of trauma. Intercostal retraction indicates impaired flow of air into and out of the lungs. Paradoxical motion is associated with fractured ribs, and auscultate breath sounds. Next, move to the abdomen. Look for trauma distension. Palpate the abdomen for tenderness, rigidity, and patient guarding. Bruising over the flank areas suggests bleeding collecting in the retroperitoneal space. Asymmetry may suggest a swollen organ. Severe distension may be caused by fluid in the peritoneal space, and assess for the presence of rebound tenderness. Always try to remember to do those abdomen inspections in the 4 quadrants, the right upper, right lower, left upper, left lower quadrant, so you can describe that pain based off of the area also. Inspect for the pelvis for symmetry and stability, pain, tenderness, crepitus, bleeding, deformity, and any other signs of injury. So, inspect the pelvic area is not often done with patients with medical emergencies. And in female patients to determine whether bleeding is coming from the vaginal opening, the urethra, external genitalia, or the rectum. In male patients, determine bleeding is coming from the urethra or the rectum. So, extremities, inspect for each extremity using the mnemonic DCAT BTLS. Check for pulses, motor function, and sensory before and prior splints or whatever you're doing to the extremity. So do each one individually. Next, you want to inspect DCAT BTLS on the posterior body. Keep the spine in line at all times. This may take up to 3 personnel because the person at the head will do your log roll. But always remember, if you are doing a log roll, you know if that patient vomiting, you may want to do it away from you. So it's time for minutes. You may perform a focused assessment of each body system. So what additional problems can be identified through this exam, and how will these findings change my treatment choices? So that's 2 questions you need to ask yourself once you're going through that focused assessment of each body organ. So addressing any potential life-threatening conditions, performing spinal mobilization if neck and back pain or abnormality in sensation or movement is identified in relationship to trauma. All right, reassessment, perform at regular intervals during the assessment process. So you want to identify and treat changes in the patient's condition, reassess the ABCDEs. It usually combines repeated repetition of primary survey, reassessment of vital signs of breast sounds, and repetition of the secondary assessment. Reassessment of vital signs, compare baseline vital signs obtained during the primary survey with subsequent vital signs. Look for trends. That's what you're using this vital signs for. Reassess the mental status and ABC. I always recommend with a trauma patient you're doing this at least every 10 minutes. And if you use a electronic non-invasive blood pressure, and it's way off from your initial baseline, you need to either do another manual blood pressure, or you need to do that non-invasive blood pressure again. So, 20 minutes with your medical patient. So a lot of times you need to make sure you follow your electoral policies and procedures. All right. Resuscitate complaint. In light of the treatments provided, is the current treatment improving the patient's condition? Is the pain going away? Is it less than on a scale of 1 to 10? Or have that vomiting sensation gone away? Has the problem gotten better, or has it gotten worse? And what is the nature of the newly identified problem? Recheck your interventions, reevaluate everything that has been done, ensure that your ABCs is the most important, ensure management is bleeding, make sure that bleeding is slowed down and stopped. Make sure your IV is in place, make sure that your ECG leads are on correctly. Has the oxygen therapy helped out enough? Maybe we can decrease it from a non-rebreather to an ACT. So identify and treat changes in patient's condition. If condition improves, continue the same treatment, or decrease, that oxygen therapy or something like that. If their condition deteriorates, modify treatments as appropriate. So unstable patients every 5 minutes, stable patients every 15 minutes. And this is the end of the chapter. include diabetes in patients with a decreased LFC. Um, these are patients that this is an assessment skill to, knock out the possibility of a glucose alteration that needs to be fixed or causing a altered LSD. So do that rapid full body scan, and this will assist you in determining the transport priority. So high priority patients should be transported immediately. Difficulty breathing patients, serious mechanism of injury, poor general impression patients. We do that full body scan. Things just do not look good for the patient. You need to get them on the road. Any alteration in mental status and severe chest pain, pale skin, or other signs of poor perfusion. That's why I said, look at that skin can give you a lot of idea of what's going on with these patients. Uncontrolled bleeding. These patients need to be at a facility that can control that quickly. Responsive but unable to follow commands. Severe pain in any area of the body and inability to move any part of the body. So protect the patient's spine and identify fracture and extremities. Also integral parts for packaging for transport. So a lot of times we may use backboards for this just to be able to quickly package these patients and get them on the road. All right, then your things tied up. Please take protective measures that are recommended to in dealing with a potential exposure risk. This type of PPE includes clothing and specialized equipment and also depends on your specific job duties at this job. So you may be asked to wear just gloves, gown, and respiratory barriers. However, the more specialized you get, you may be asked to wear a full turnout gear set or level A hazardous material suit. So do assume that all blood and bodily fluids except sweat, non-intact skin, and mucous membranes may pose a substantial risk for infection. Include potential infectious materials that are dry. Most effective way to reduce your risk of exposure is make sure you have your proper PPE on. So take standard precautions before you step out of the EMS vehicle and before you make contact with the patient. And also, just keep in the back of your mind, if you do have an NCI situation, stick a couple more sets of gloves into your pockets. That way you can assess those other patients also. So a sign is objective condition you observe. A sign is something that you see. A sign is something that you can look at the patient and say, hey, you are having respiratory difficulty, or hey, you are you do have a laceration. I said it's a subjective condition that the patient feels. The patient tells you that they're having chest tightness. A patient tells you that their arms hurting or their legs hurting due to something. So a chief complaint is why the reason EMS was called. And it needs to be the reason why EMS was called today. A patient may have multiple complaints, but you need to narrow it down and get a defined chief complaint on what that patient needs and wants to be treated for today in this instance that occurred.